Where do you see the most potential to take meaningful costs out of the healthcare system, not just incrementally, but structurally, in the areas like fall prevention, medication reconciliation, or in-home care? Are they still under-leveraged?
You said my favorite word, fall prevention, so thanks for that.
I made sure I touched on that.
As we talk about, I think, cost is the big thing in the Medicare Advantage world right now. And so I think when we look at it, and there's a reason we're doing fall prevention, which is, you can try to shave another marginal dollar off your CHF patients or whatever you're trying to manage, or you could look at an entire, what we call unoptimized cost center, which in our case is fall prevention. And what's been unlocked? It's, if you look at the past 5 years post-COVID, older adults in Medicare Advantage are now tech-enabled. Most people, some studies show as much as 90% of older adults now have a smart device in their home. Health plans have been slow to realize this, but you have this opportunity to deliver care directly to an older adult in their home that they can direct, or you can direct, however you want to do it, but you can deliver that care in a way that they want to consume it. And I think health plans have been slow to see that. But once you do see that, it opens up entire approaches to population health that we haven't had before. And so we look at fall prevention as a big one because, about 1 in 8 Medicare Advantage members a year is going to have an injurious fall-related claim. Well, how do you deal with that? You can't just tell people, go to your annual wellness visit, and then the physician or nurse practitioner, whoever, says, well, go to the YMCA and take their balance class. While the older adult has a smartphone right there, you have the ability to deliver care. So, where we're seeing traction is coming to Medicare Advantage plans and saying you have cost pressures. There is an entirely unoptimized cost driver here in falls. Everybody's falling. We have a solution that we can give to you. And by the way, we'll do it with zero risk to you because we'll put all of our fees at risk for reducing cost on the ED and inpatient side. And so I think when you combine that opportunity to distribute something via technology to an underserved condition with that sort of risk-based approach where you come in a true partnership fashion, we've been able to see some success there. So I think it's all about unlocking these areas that haven't been looked at before because we haven't had access to patients in those ways.
You said my favorite word too, which is medicine reconciliation. 16% of our total healthcare spend, it can be tied directly back to medications not working as intended. So there is no larger avoidable cost than just fixing the way we prescribe and manage medication therapy. It's ridiculous that we rely as heavily as we do on trial and error prescribing. We mostly disclude pharmacists from a collaborative care model, which are the people that really understand pharmacology at the level that is necessary. And instead we rely on trial and error. And it doesn't have to be that way. We've got the knowledge, the clinical science, the data science to make much smarter, more proactive and personalized decisions about medication therapy. But it's a data challenge, and we don't have the right data in front of the prescribers at the right time. That's the gap that we fill with DecisionRx is we introduce a clinical pharmacist into a virtual collaborative care team. The pharmacist has access to all the appropriate data, including genetic data even that we pay for out of our own pocket, because the pharmacist needs that data stream in order to make a fully qualified recommendation to the providers. And so it's really just about giving them the right information so that they can deliver a higher standard of care. And nobody sets out intending to misprescribe. When they have the right data and we make it easy for them to make better decisions, they overwhelmingly do. And there is no larger lever you can pull in a value-based care model than just getting people off of drugs that don't work and on the ones that do, that manage chronic illness, that keep them out of the hospital. It's got nothing to do with the price per pill. It's got everything to do with prescribing the right pills and avoiding the utilization that comes from being on the wrong drugs.
Yeah, there's so many things. I think that general theme of trying to work upstream still brings into view tremendous opportunity, whether it's falls or medication adherence. And we're finding with the insights we bring to providers that they're diagnosing diabetes on average about 3 years earlier, so they can intervene earlier, CKD a year and a half earlier. There's high correlation for CHF patients. If the provider is using our technology, that admissions are about 18% lower, readmissions about 25% lower. That all drives results. So that theme of having the right information and then connecting at the right point can harvest a lot of that opportunity. I think the specific, you mentioned home care, we've got a division that treats our highest complex patients in the home. So we take the care to them. It's great for member satisfaction. The NPS scores are off the roof, as you would imagine. But the impact on cost is tremendous of just taking the care to them, really holding their hand through the process, understanding everything that is going on, that they're getting their meds, that there aren't fall risks in the home. That's a part of it, right? So I think there's a lot of sort of puzzle pieces joining in that space as well.
I think some of the things, we tend to think about cost as longitudinal, right? So it starts here and it goes up on a straight line over the course of the year. And that's just not how cost happens in healthcare, right? You're healthy, you're healthy, you're healthy, you're healthy. Ooh, you know, I was talking about the other day, my dad is a 72-year-old skier. He's healthy, he's healthy, he's healthy. He falls on the black diamond, the last black diamond of the day that my mom told me he shouldn't be skiing on, boop, right? And then he's gonna be healthy again. And so while we can't prevent bad decisions by my dad on the slopes, we can, from a perspective, prevent sort of the rising risk. And I think there's a lot of companies out there and a lot of solutions over the last 15 years who've been like, go find the most difficult patients that are sort of bouncing back and forth between the hospital 5, 6, 7 times, wrap a lot, care services around them, and you'll be safe. And the reality is, I think that's kind of baked into the system. I actually think the actuaries have sort of understood that there is a percentage of the population that's going to drive a significant amount of the spend. What we find is find the rising risk, right? Try to see if you can get in the middle of things before they happen, sort of this prevention. And to do that, you have to go broad, right? You can't necessarily go narrow. You can't just say, I'm going to wrap my services around this top 5% of the population, and thereby I'm going to decrease spend for the totality of the population. You're going to help, don't get me wrong, right? You have to be targeted there. But sort of branching out over the entirety of the population, and that's actually going to drive significant cost savings across the totality of the population.
I just want to underscore 2 of the points that you guys made, which I think were great. The first is getting upstream of things. And we did this work with Chris and Arbital. Your healthcare costs, at least with falls and with a lot of other conditions, you're here, something happens, it spikes. You don't come back to the baseline. You're now up here a little bit, and so you cost more money. And so if you can get upstream of that and prevent that event, that shifts the whole thing downstream. So I think getting upstream is very important. Second thing is, I think, trusting the member or the patient, or in our case, the older adult, to kind of know what they need and bringing them into the circle. And you talked about this a little bit, which is, people ask us all the time, do you target high-risk members? How do you find people for your fall prevention program? The answer is we give it to everybody across the population in the MA plan. And the people at fall risk know that they have bad balance, they know they're struggling, and they're the ones that sign up. And so when you look at our risk profile, we have higher risk members naturally signing up. Why? Because we trust an older adult to know what's right for them. And so I think we're talking a lot about payers, providers, but at the end of the day, it's the member, the patient, who has some problem, who needs help. And if we trust them a little bit more, bring them in and allow them to make decisions, now they're bought in, you start to see better outcomes, better engagement as they go through that journey.